Great, that looks like everyone is in. Welcome, everyone, to the Operations Committee meeting of the Universal Health Plan Governance Board. Our committee has this meeting and I believe one more, and I want to thank you again for your time and your attention and your work. I'm a little biased, but I really think that we've had the best committee, most highly functioning, productive committee of all of them. Bias declared. Go ahead. There we go. Isabel, can you help us with a roll call, please?
Bruce Goldberg is on leave. Judy Richardson,
I'm here.
Mike Leahy. Mike, I see you. If you're able to unmute, we can come back to you. Laura Byerly, I don't see Laura yet. Doug Flo, I don't see Doug. Sarah Fouché,
Here, yes, hi.
thank you. Lori Hoagland,
Here.
thank you. I don't see Michael Horay. Doris Karagu,
Here.
thank you. Anne Lovejoy,
Here.
thank you. Paula Weldon,
Here.
thank you. And going back to Mike Leahy, are you able to unmute?
Here.
Thank you. That's everybody.
Great. Thank you, everyone, for joining. And Isabel, if you don't mind, if you see other committee members show, please let us all know so we can welcome them into the meeting. So I respect everyone has busy afternoons and are in lots of different places. So we really appreciate all of your time and the time you can commit. Let's take a look at the agenda here. So we're going to have a committee and board update. Thank you, Director McDonald. We'll have a briefing on the interaction with federal health systems. This is a presentation that our senior policy advisor Lee has really helped us with. So that will be a really interesting learning opportunity to see about all those other kind of adjacent insurance and microsystems within our system. Mimi then will launch into the information system strategy by giving us a peek into what is happening in Washington State. Fascinating model for us to learn from. Then we'll take any community member reflections and think about our next steps for our final meeting. Is everyone okay with the agenda? Any changes or objections to that agenda? Also public comment. Great. Well, take it away, Director McDonald. Thank you.
All right, thank you. Hello, everyone. It's Mimi McDonald, Executive Director of the Universal Health Plan Governance Board. As always, thank you very much for attending. I can't play favorites with committees, but anyway, I think Dr. Richardson had some excellent comments. All right, so I'm going to give you some updates about what's been happening at the board and with some of our other committees. So the board, we just had a meeting, just I always have to look at my calendar. It was just last week. It was great. Where the Chair Belanca went over sort of the board timeline and the timeline of the various committees. We did, or I helped with, and with help from Milliman, went over the Milliman expenditure data again, kind of broke it down a little bit about how they sort of got from one place to another, and people had time to answer questions, and Milliman was there, and I think it was really beneficial. We got to hear from Dr. Chunwei Chi, which was fabulous, about International Universal Health Plan efforts. We had proposals put forth about subrogation and also enrollment. Thank you very much. And then also a behavioral health payment proposal. So very, it was a very productive board meeting, I would say. Anything else you'd like to add, Mike or Chair Richardson, about the board?
No.
Nope. Okie doke. Oh, I will say, I should have added that on there. I realize this is what I get for using an old template. The transition committee was officially approved by the board. So not only that Judy Richardson and Mike Leahy will be co-chairs, but then also all the members who are going to be on the transition committee, including Mary Lou Henrich, who one of the other board members, who's going to be on the committee. So we're excited to get that going. All right, next, finance and revenue. Continuing to do incredible work on the revenue strategy and really narrowing down the strategy around reserves and startup costs, how those can be developed and thought about. Plan design and expenditure. Lee Hastings gave a great discussion on, led a great talk about the prescription drug system and a lot of the complexity there. Cost containment was also on the agenda at the last meeting. That will continue to be on the agenda, I think, for with transition as well. The portion of the enrollment proposal that this committee deferred to plan design is actually going to be on the docket for plan design. So that will be, as you guys remember, kind of the question of if when people enroll in a universal health plan, are all benefits available immediately, or would there potentially be a waiting period? And if there is a waiting period, what would the benefit change be between, sort of partial benefit plan and full benefit plan? So that will be interesting, and that's coming up at the next meeting, which is next Thursday. And then the other thing that we're going to do at that meeting is go into the Wayback Machine for plan design and expenditure and go over all of the proposals that they have put forth, and to highlight areas where they think, I feel like this is important, and I feel like there might still be another question or something that we really think should be addressed before the final report. And we'll have an opportunity to do that in operations at your final meeting as well. And then last, certainly not least, our community engagement and communications team are working incredibly hard setting up these strategic engagement meetings there. The work is fast and furious with huge input from our consultants and also from the chairs. Michelle Glass and Amy Fellows have done just tremendous work. Also shout out to my staff too, who are doing extra work for that. I'm so grateful. But that's going to be exciting. The month of March, we're going to have somewhere between 15 to 18 meetings with these targeted groups to get feedback on where the plan is now. And I think that's going to be fascinating. The other thing that community engagement and communications is doing is their regular meetings are resuming in March, but in order for people to be able to attend outside of that sort of 9 to 5 timeline, they have generously agreed to shift their meeting time between 4 and 6:30 p.m., excuse me. And they're also setting a time strictly for public comment, and that will be between 5 and 6 p.m. So people will be able to comment. It will be public comment. It won't be sort of that back and forth. So it'll be kind of like what happens here. And at the board meetings, people have a slightly extended time, maybe like 5 minutes to be able to provide commentary. So let's see. And I am going, if there aren't any questions, I'm going to turn it over to my colleague, Lee Hastings.
Thanks, Mimi. I do want to welcome Doug to the meeting as well. And
oh,
thanks. Take it away, Lee.
There we go, off mute. Yep, I am here to talk to you today about some federal healthcare programs. So let's dive right in. Next slide, please. So we've discussed this, but just kind of setting the groundwork here. We know that a statewide health program is possible to coordinate with federal health programs, but it does not have the unilateral authority. States simply cannot make changes to federal healthcare programs without cooperating and getting specific approval for that. So we're here to talk about some of these federal healthcare programs that thus far have kind of flown under the radar. So what I have listed here, these are the 6 kind of major buckets of healthcare programs. Medicare and Medicaid are grayed out because these have actually received quite a bit of attention, as you might imagine, due to their size. But what we haven't really looked at so far, and what we're hoping to understand from this committee, is some direction related to Veterans Affairs, TRICARE, Indian Health Service, and federal employee health benefits. Next slide, please. All right, so I wanted to put this a little bit in context, and this graphic on the right, it's far from perfect, but this was actually the only graphic I could find that even called out the fact that, there's like the VA and some of these smaller federal healthcare programs. So I included it for that reason. There's a small little black bracket that you might see indicating where the chunks of those programs that we're talking about live. So, it's definitely a smaller piece, but still, substantial one.
And when we're looking specifically at Oregon, that's what this table on the left really helps us identify is within these programs, how many covered lives do they have? And then because of the unique nature of these programs where they're often not the only way of getting care. We also have this column noting what are the active users. So in many cases, folks maybe have a card for something, but they're not necessarily going into the VA for their regular care. And so in that case, we would not consider them to be an active user. And as we look at these numbers, we see that the covered lives approximates a little over 7% of residents in the state, and a little over 4% of those are actively using these other federal healthcare programs. Next slide. So we're just going to march through these one by one, starting with the VA, the Veterans Affairs Health System. So I'm sure everyone's familiar, but I just want to make sure we're all on the same page here. This is federally financed healthcare system for eligible veterans. This is run by the U.S. Department of Veteran Affairs. For the most part, this is what we would term a care delivery system. So this is its own actual, network of hospitals and kind of outpatient centers and clinics. As you can see in that third bullet, here in Oregon, they have 2 inpatient care sites, 5 kind of broader scoped vet centers, and 23 outpatient care sites. So they actually have their own independent delivery system. Now, they can at times act like a payer, as we'll see in sort of that second bullet there, because they do have what's called the Veterans Community Care Program, which essentially authorizes payment outside of that VA system. This is typically where the VA system can't accommodate some sort of specialized need. And so in those instances, the VA will pay for care to be provided at one of, those other providers that exist outside their own system. So currently this operates very much in parallel to our healthcare system. And again, you'll see just some of those numbers there about, the number of veterans in Oregon, and then approximately half of those enrolled with the VA. And then the VA has, or at least in the latest year for which I could find data, had about 96,000 unique users in that particular year. Next slide. So all these will follow the same format, just so you know, a little introduction, and then kind of talking about how this could interact potentially with a universal health plan. So, the reality is that the VA is federally owned and operated. This is something that the state cannot just, decide what's going to happen to it. That funding is all done at the federal level, and not a single bit of it flows through the state. So it's even further removed than something like Medicare or Medicaid, where there's a matching component. This is really its own contained system right now, and the state has really no way of even getting into that system. To change this would require some federal changes at the statutory level. So we're talking about federal law here. Now, something that is possible with respect to coordinating with the VA are MOUs, which stands for Memorandums of Understanding. Those have been used in certain contexts to improve data sharing and care coordination, particularly when there are veterans that are kind of going between systems, between VA care and between community care. So on the side here, I've listed a bunch of options, and I'll be clear, when I list these options, it's just to try to be comprehensive. Some of them are flat out not possible, but I wanted to include them just to show that, this is what we're thinking about. So in terms of, folding the VA into the UHP, that's a pretty firm no, unless you want to go down the path of trying to get congressional action. And, as an attorney, I would not advise that personally. There is replacing the VA with UHP coverage. Also a no, this is an entitlement program. We'll see this again with the Indian Health Services. And because of that, this just cannot be replaced. This is something that is owed to veterans in response to their service. Now, as we're starting to look at things that are more feasible, parallel systems with coordination, yes, this is absolutely possible. Again, using those memorandums of understanding, there could absolutely be agreements created for wraparound coverage and improved care coordination, possibly even going as far as a little bit more IT coordination. That would, of course, all have to be negotiated, but that kind of lives within that realm. Now billing, this one gets a little bit tricky, but whether the universal health plan could be billed as secondary, really just for that non-service connected care. And that's again, because this is very much an entitlement program for those veterans. So my strategic assessment, and you all can, certainly debate me on this, but just, that full integration is just really not possible. But strategy could really align around how do we coordinate, how do we work with this system. And I'll just note that the Joint Task Force recommended essentially having the VA continue to operate in parallel as well. So it would be in alignment with that previous recommendation. Next slide, please. And if folks have questions, feel free to raise your hand, just because I am kind of going one by one, so we can address it in turn. Oh, no, I have a couple more here on the VA. So thinking a little bit more about those interactions that the VA could have, again, because the VA really is kind of its own insular system, a UHP would almost just lay on top of it. It's not going to change any of those things. So enrollment for the VA would, of course, remain its own process and eligibility for that, completely separate from what a universal health plan. Payment delivered, some of this gets slightly more technical in terms of how the universal health plan might want to frame things with respect to, whether those things are in network or out of network. So for instance, designating those VA facilities as out of network and not billable, meaning someone seeking care at the VA, is not going to get reimbursed by the universal health plan, which is, very consistent with how it's done now. You can't just walk into a VA facility with your private health insurance either. And then payment, of course, not being reimbursable if it's provided in one of those facilities, but having that care coordination such that there can be good information flow between the two systems, I should say. So I'll just pause for any questions there. Got a little repetitive. Okay, let's move on. Oh, I do see a hand. Lori.
So I know from personal experience working in an FQHC that we saw quite a few of the past service members for healthcare. And I wondered, in terms of decision making, is there any process already where there's a way to I guess refer care, or is it at the discretion of the patient?
To refer care like into the VA? Is that what
Or
you're
out
asking?
of the VA if they want to get care at a clinic?
Yeah.
Can they just self-refer for the most part?
That's a really great question. I am not sure under current circumstances. I would hazard, given what's proposed for a universal health plan, that they probably could, though, because if they are a resident in Oregon, whether or not they have that VA coverage, they would continue to have universal health plan coverage. So as currently proposed, I would say they would.
And right now, they'll often have, correct me if I'm wrong, sorry, just to jump in, they'll have a supplemental, so they can go get care somewhere else, and a supplemental applies, and that, whether that's CHAMP VA if they're for their dependents, or it's a supplemental insurance. Is that right? Yeah, I mean that, and so your logic stands. They would qualify for universal coverage.
Yeah, it's a great question. Yeah, we'll zip ahead to TRICARE. Perfect. And this one I put second because this is also very military related, but this one, unlike the VA, is really kind of a true insurance program. It doesn't have its own facilities. It is a payer. It has its own, networks, just like we would see from any other kind of commercial insurance program. So this is managed by the Department of Defense, and it's available for active duty retirees and their dependents. So again, a federally financed system. Importantly, federal law does allow it to explicitly preempt any state or local law related to health insurance. So what that means in layman's terms is that as a federal health insurance program, it doesn't have to follow state laws around things like network adequacy. So it gets to kind of decide what it determines is an adequate network, and it can go with that. States, just under, basic constitutional premises, can't tell the federal government what to do. So this is how that kind of plays out in a health insurance context here. So importantly, as TRICARE functions as an insurance program, just really wanting to think about how that interacts with other insurance programs. TRICARE is always going to be primary coverage for active duty service members. So those that are in an active role. For everybody else, so for those dependents or for those retirees, TRICARE is secondary if there is alternative coverage. So a dependent, this might be their only care, in which case everything is currently covered under TRICARE. But to the extent that there is another health plan that covers them, TRICARE would become a secondary payer. And you can see there, of course, the number of TRICARE members is around 63,000. When we're looking at those active duty service members, so the folks that would, definitely be covered by this as a first order, we're talking about 3,500 people. Next slide, please. Sarah.
Yes, can you go back to that last slide?
Sure.
Pardon me if I missed something.
Mhm.
So for the active members, would we be asking for reimbursement if they go to because it's not like VA, it's not integrated with the VA, right?
No, this is separate. This is like standard insurance.
So would we be asking for reimbursement from TRICARE for care provided to the active duty?
I think that is that's part of what we're hoping to understand from all of you is
Yeah.
should we ask them for reimbursement?
Got it. Okay.
Yep. Great question. All right, so in terms of TRICARE and its interactions, again, this is not something we could just fold into the UHP. It would require congressional action to change that, to allow opt-in. Gets a little bit tricky simply because you start talking about how are you going to reflect that on taxes, and especially when an employer is paying. So that gets pretty complicated with respect to the financing of it. Secondary payer coordination, yes, that's absolutely possible. Notably, TRICARE is generally going to be secondary to the UHP under this scenario. So we do have a little over 3,000 active service members where it would be primary, but all those dependents would, under a universal health plan, automatically have additional coverage. And so that would then become the payer of first resort, essentially. And provider contracting alignment, yes, this is something that could absolutely be done through kind of trying to work with some of these systems, trying to harmonize that payment and how reimbursement is done. Has to be, of course, a negotiation and a back and forth. So strategically, this is also kind of a closed federal system, not in that it has its own facilities, but in that it gets to follow its own rules, and it has its own funding source, and that money does not flow through the state presently. That money goes directly from the federal government to providers. Next slide, please. So similar considerations here, that TRICARE eligibility and enrollment, that is not something that we would touch. That remains the purview of the Department of Defense. Payment, so this is definitely where it gets interesting. Since TRICARE is secondary to other health insurance, and that's in quotes because that is actually a legal term, their other health insurance, we could expect to see some shifting of cost from the Department of Defense to a universal health plan, because we do, again, have people where TRICARE is their only plan, and that's how they're receiving all their healthcare services. It's all reimbursed through a TRICARE plan through the Department of Defense, and that would then become a secondary payer. So a universal health plan would then take on those costs. And, we're not talking about huge populations here, but it is something worth noting. And then just again, noting that those TRICARE networks are federally managed, not something that we would be able to manage. And next slide, please. All right. So the Indian Health Service, and this bears a lot of resemblance to the VA in two key ways. One, it is its own system. It has its own facilities. It's really more of a care delivery system than a payer. And two, this is an entitlement program. Specifically, this is a federal trust program. So, you know, similar in the respect that both those programs are not things that, you know, this state could get rid of, even if it was trying to negotiate with the federal government. Just because of how they're structured as entitlements, they have to exist in addition to any other kind of healthcare that is out there. So the Indian Health Service provides those health services to federally recognized tribes, again, as part of its trust responsibility. Tribal sovereignty is a huge deal when it comes to the Indian Health Services. They are their own governments. They need to be consulted in addition to the federal government regarding anything that's going to potentially impact this care system. States are required to treat the Indian Health Service as the payer of last resort, meaning that they look for every other kind of insurance and coverage before they charge anything to the Indian Health Service. And also just worth noting, because it does have some implications as we look at payment and where some of these costs could go, but a lot of IHS members are also enrolled in Medicaid. So bringing Medicaid into a universal health plan would actually capture a fair amount of these associated costs. And as we're just looking at those numbers there, we see about 67,000 Indian registrants, and then active users for the last year that we have data available, just over 26,000. All right, next slide, please. All right, so again, I listed all these options, even though some of them are just flat out never going to happen. So replacing it, no. Redirecting those funds, again, that's a pretty hard no. A tribal opt-in, this is something that is possible, but again, that sovereignty element is so critical. There has to be an affirmative opt-in by those tribal groups to say that they wish to participate in the program. This is not something that the state gets to decide. That is absolutely their purview. Something like a Medicaid style wraparound, yes, that's absolutely possible, especially if, as is planned, Medicaid is brought in via the waiver to a universal health plan. This becomes a really organic, natural way of essentially supporting Indian health services with the universal health plan. So that's definitely possible. And then looking for those federal matching, this is really kind of tied to that other one. Yes, of course, the hope is that for any Indian Health Service users that are currently on Medicaid or otherwise receiving a federal match when it comes to paying for healthcare services, that's something that, you know, we would absolutely want to preserve, and it seems pretty likely if that mechanism is through the Medicaid program. So yeah, I don't think there's too much that I haven't already said on the left here, except maybe just to emphasize that last bullet, which is this is a population that's very politically and legally sensitive. So everything here related to Indian Health Services should be done very thoughtfully. Judy.
I really appreciate that comment, and I will add to that unlike the VA system, the IHS system, there are access issues for folks who are participants in the program, and most of the time need to seek specialty care outside of the IHS. So that really does, and we have good models for how that works now with referral coordination, and so it kind of like lays a pathway for how this can be done with us.
Yeah, thank you so much. All right, next slide. So a lot of those same considerations that we've been talking about, but when it comes to enrollment, you know, the recommendation, at least from staff, is to treat individuals who use IHS or tribal services as having that parallel system, similar to what I think we're going to probably see with the VA, and avoid processes, you know, absolutely that condition any kind of coverage on enrollment or anything of that sort. You know, the state plan could absolutely treat some of those facilities as in-network by default if that particular tribe chooses to participate, in which case those services would be able to be covered. But of course, again, not asserting any control over the clinical governance of those facilities. They operate independently under their own framework. Care coordination, this is really, I think, the big opportunity, similar to what we saw with the VA. There's, I think, a lot that can be done with respect to standardizing certain elements, referral pathways, et cetera, and really smoothing transitions between these care delivery systems. That's really the key point that I wanted to make here. All right. And this is our fourth of the smaller federal healthcare programs, but one that I think gets forgotten a lot, which is federal employee health benefits. So like any other, kind of employee that's receiving health insurance through their employer, we have federal employees, and they get that insurance directly through the federal government. And because it is directly through the federal government, we have that same preemption that we saw with TRICARE, where the federal government is not obligated to follow state rules when it comes to networks and certain other insurance provisions. They really get control over how they want to design that, and those dollars do not flow through the state, but of course go directly from federal government to those covered plans to the providers. So figuring out how to incorporate that, kind of an interesting brain twister. So this is administered by the U.S. Office of Personnel Management, and again, not subject to that state regulation. Broad preemption and number of covered lives. This is an extrapolated number, so I'll be honest, I don't know how accurate it is. I think it's probably in the ballpark though. So we're going to say around 43,000 individuals in Oregon are probably covered by this, and this would include, of course, federal employees, retirees, and their dependents. Next slide, please. All right, so replacing federal health benefits, again, this is a hard no. Congressional action, the fact that the federal government can preempt anything from the state just makes this really not feasible under current and I'll say very, very well established laws. The UHP as a secondary payer is absolutely possible that if someone were to have their federal health benefit, that they might be able to go in and get wraparound coverage or some sort of coordination of benefits. Of course, someone living in Oregon under the current proposal would be covered by a universal health plan. So this would, again, under our current proposal, really be the default that a universal health plan would automatically become a secondary payer if there was other coverage. The final one, possibly somewhat controversial, is federal employee buy-in. And this is essentially trying to capture some of those federal premium dollars for the state. So what we have here is a situation where the federal government, like all employers, is paying a certain percentage of those premiums today. And if individuals are no longer covered under their employee health insurance, those are additional dollars that a universal health plan would be paying on their behalf. So this is something that's theoretical. There is some legislation being discussed at the federal level that would allow this with waivers. But as of present, it does require a change. So I didn't put it as a total no, just because it is an idea that is out there being discussed. But currently there is nothing in federal law that allows this. All right, and so a lot of the same here. That enrollment, of course, is determined through federal employment processes. So enrollment in federal employee health benefits is not something that a UHP would get involved in. Payment, this is, I think, the most interesting space, trying to figure out when and does a universal health plan pay secondary or is it primary, as well as that question again of how does one account for those premium dollars, that used to maybe be paid towards someone, but given that they're already paying into a universal health plan. They just decided to go with, state health plan coverage. So some interesting questions around that. Again, noting that those federal networks are carrier networks, so these don't have to align with anything that a universal health plan is doing, such as our, commitment to having no networks. And once again, care coordination really being the space where there's probably the most opportunity to try to harmonize things between what the federal government has and what the state has. Judy.
Thank you. This is really clear. Sometimes this work makes me feel like my brain is in a pretzel trying to think about how this actually works. Is this similar to how we might think about someone who lives in Oregon, but they work for an out-of-state company, and as part of a condition of their employment, they have employer-based benefits? Would that be similar, or is it not?
I think that's similar, yes. Yeah. And that's a very real thing that will happen, especially, for those employers that are working for employees, excuse me, that are working for multi-state employers. All right, let's jump forward. So just a quick summary here. I think the key thing that I just want to reiterate here is what we have are kind of two types of functions. We have the VA and the Indian Health Services that really operate as care delivery systems. So they have their own facilities and providers, and they can refer out of those systems, but they can also be somewhat insular in that care can be delivered and paid for, and someone could never leave that system and be, perfectly fine and treated for all that. On the flip side, we have TRICARE and the Federal Employee Health Benefits, which are truly insurance programs. So what we're more used to today, where they build networks, where they go out to whoever is in their network, and they reimburse based on those services. Then I think the other thing worth noting is just that dual coverage hierarchy. Those instances where a universal health plan would be considered primary, where, if you're in the VA, of course, the VA is going to pay, and federal health employee benefits, we just don't know because we haven't really tackled that. And I'll just note that asterisk under TRICARE is just noting that the UHP would be primary for the majority of those folks. But again, for those active duty service members, TRICARE remains the first payer. Lori.
I'm just trying to understand, enlisted people could be part of the VA system or the TRICARE system.
Mm-hmm.
And if they are, and what determines that? Is that location? Is that disability? And are the enlisted TRICARE folks primarily seen in the VA health system, or is it strictly considered insurance?
That's a great question. I'm not entirely certain about that. I would have to look into that. Yeah. All right, any other questions? Okay, let's move forward. Okay, decision points. So we're really at the point where, staff are kind of curious and would love to be able to bring forward, to the board, maybe some thoughts as to how a universal health plan should approach these other payers, these other care systems. So I've split them into two based on kind of functionally how they operate. So first question is just whether care delivery programs, this would be veterans and Indian Health Services, should be treated as a carve out or a wraparound. And the distinction really is, if it's a carve out, we're really treating it as its own system. We're not going to touch it. We're going to let it do its own thing entirely. It operates in parallel. Wraparound would mean doing more of those memorandums of understanding, of really trying to work to do the care coordination, potentially integrate some of the IT functions, etc. So it's how much we want those systems to interact. Chair Richardson, I don't know if you want to address these one at a time or just have me go through it all.
I don't have a preference. Perhaps one at a time would be easier. What does everyone think? What does the committee think? How do you feel? Do you have more questions? Do you want to discuss these individually, or should we? I appreciate the way the tables lay out what's possible and what's not feasible. Yeah, go ahead, Paula.
Um, so so what you were saying is like with IHS, it's the Medicaid system is where we have an opportunity, and that's really kind of a low barrier. That's just how it would, could happen. Which one is that? I'm trying to, from wraparound versus carve out. Sorry.
Yeah, it's a great question. The wraparound versus carve out is, I think the difference is really asking, do we want a universal health plan to try and coordinate with these systems? Or do we just want to say, you're a care system, you deal with a very specific population, do your thing?
So the only thing, yeah, I was thinking about that from a VA perspective, because they do refer out. They do need to have care. They will need to have care with, and I think they will have to interact with universal health plan because they will need to have care outside their system. So we would have to figure that out. I guess that's my comment on that one.
Lori.
I guess I also think about the rural component and the distances for urgent care needs. And then, of course, also if there's a way to access information. I know one of the frustrations, having worked with patients who mostly live in the VA system, is it's really hard sometimes to get information out of that system. So I think the wraparound may actually create ultimately more convenient and higher quality care.
Thank you for that comment. I agree. I was thinking the same thing. It's like, when we have kids who are in school and they need to find their immunization records, for example, it can be really cumbersome and difficult. And that's one benefit of a universal plan, is that you can have some data repository that can share and be accessible to multiple care providers. And oh, I can't hear you. You came off mute, but I was having tech issues too today. Might have, yeah, access to the chat.
Yes.
Okay.
Yeah, let me know.
While Anne's writing, I think if we, ground ourselves in the principles of the board and even the task force, thinking about Oregonians and as a whole, and wanting to provide a unified care system for everyone and not create systems of inequity, I think it argues, this is my opinion, I think it argues for as much collaboration and coordination as we can possibly provide and bring into the proposal. Oh, there we go. Anne saying, I favor wraparound, patient first, care coordination, better quality data. Yes, thank you. That's what I was thinking too. Great. Other thoughts? Anyone feel strongly that there should be a carve out? Great. Yeah, Anne. Working on tech. How do we think a universal health plan should treat individuals who are covered by the federally administered insurance programs like TRICARE and the federal program? We heard a question about, well, can we go and bill TRICARE or bill the federal program. Other thoughts about that one, the second question?
Yeah, and I'll just note, sorry, because I don't think I
Go ahead.
explained B very well here. So under B, there's this idea of a contribution adjustment or exemption. So if folks are paying into, their federal health benefit premiums, should they get some sort of credit then on, on the taxes that we're asking them to pay towards a universal health plan? Or is that just, how it works?
Thoughts about that one? We see something similar in some settings, for example, college students, where if the university requires that the student carry health insurance, if they can't show proof of insurance, the university charges them a certain fee, and if they can, then they credit that towards tuition and fees. Personal experience. Anyone have strong feelings or thoughts about this one? Yeah, Sarah, thank you.
Regarding number B, not number, letter B, contribution adjustment or exemption, I kind of saw two different figures for the TRICARE, 3,000 something active duty, and then estimated 12 to 13,000 who are receiving the coverage. So I wasn't totally clear on the difference between those numbers, but if it's 12 or 13,000 people, I don't think we could ignore them. I think that would come around to bite us, and it would be more people complaining about the idea of a universal health plan. So I think we do need to consider some kind of adjustment or exemption to prevent possible complaining, opposition, to prevent possible opposition.
Mm-hmm. I mean, I could counter argue that and say there's a large chunk of these folks who qualify and they're not taking advantage of the benefits that their employer are paying for already. And I don't know the why behind that either. Are they healthy? Can they not access? Are they just haven't used it this year and that's the way the measurement was? I don't know. Lee and Mimi, what would be helpful to the board from at this point coming from the committee?
Well, there seemed to be a very strong consensus on the care delivery programs, which is fantastic. So we can give them something clear there. I think just relative to the federally administered health insurance programs, there's the question about the contribution, and then there's the question about should a universal health plan operate as a primary payer or as a secondary payer when there is other insurance coverage available? So whether there's just some thoughts or wanting staff to explore the implications of some of those options, that would just be helpful so we can continue moving forward.
Mm-hmm.
Yeah,
that-
and
Go ahead,
if
Amy.
I could add also, I certainly all of the excellent questions that people have posed, that's tremendously helpful, because if you are thinking of them, that means I'm certain board members will think of them too, and those are things we should look into. And one of the things that I was thinking about, which I think I know the answer to, but we need to look into it, is that federal employers, for the most part, do not pay state taxes. So if there were to be an employer payroll tax, would the federal employers pay that? I don't know the answer to that, but it is this conversation that you all are having is one of the things that I think we'll need to look into. When you think about that, a contribution adjustment or exemption and things like that, it does get very complex.
I think it is worth having an answer for the report, right? But perhaps requires a little more
Yeah.
investigation. Any adjustment or exemption is going to require more administrative work, right? But it may be unavoidable. Yeah. And to Sarah's point, like we want support for this plan as well. Okay. Great discussion. Thank you, everyone. If we're ready to move on, Mimi, you can teach us about Washington and what's going to. Oh, hi, Doug. I didn't mean to skip you.
Can you hear me okay?
We can.
I'm just curious, everybody is going to be contributing some level of tax to this effort, correct? Is it tax-based? My understanding is this would be tax-based as a foundation, if you will.
Mm-hmm.
Is that correct, or am I wrong?
Certain income levels. Mimi, can you talk about the current revenue strategy?
Yeah, I sure can. And you're right. So households who have incomes above 200% of the federal poverty level, there would be a personal income tax, again, levied per household. So you're correct there, Doug, that there is, but that is, on people's personal income. People who are employed, their employer pays on their behalf a payroll tax as well. I won't get into all the tax credit part, but those are the two. There are some other bases. Those are the biggest ones. There's smaller contributions from corporate income tax and corporate activity tax.
But starting at 200% federal.
This is complex. This was a complex question you're asking. I hate to drag things out, but I think it needs to be thought through a little bit more.
I think you're right, Doug.
Mm-hmm. Mm-hmm. Agree.
It is complex. I mean, it could be something that could kind of pull the rug out from the entire effort if we're not careful. In terms of confidence in the beginning, in terms of confidence, public confidence, et cetera. On the other side of the coin, the effort needs the funding. If people are going to participate somehow, some way, there has to be some payment, if you will. I'll stop there, guys.
Thank you for your thoughts, Doug. Yeah,
Well,
you're right. And I
for what
think
they're worth, anyway.
no, it's great. And what I think we've done is ask staff to continue to pursue the implications of those options and then really think through it. It's really worth having that answer for what happens to these populations. And what I would add to is underlying with the foundation that our intention is to abide by the principles of the board in a universal plan, and that really supports collaboration, coordination, and coverage of everybody rather than exclude.
This may go back to your middle statement earlier in the previous slide. Where would it go? An adjustment or exemption, I guess, is the answer. I would say, I believe other people already voted for that.
Sarah.
Yeah, I think I'm agreeing with Doug in that we there's only so far we can comment without financial assessment. And so I hate to punt over to finance and revenue or plan design and expenditure, but it's hard for us to discuss this without that type of assessment that Eco Northwest and the M1.
Yes, we're doing it at a kind of a concept level here.
I appreciate
somebody has got to look at the nuts and bolts of this before it's over. So
I appreciate the call out there and the nature of this committee. We've functioned before getting all the information, the data, noodling on it, and then making a decision at the next month. And this is kind of like we're getting to the end and the dregs of what we need to kind of give some direction, or at least like put our finger in the air and let the board know which way we think the ship should go, and then allow them to continue to do their work and call on and bring all of that work together, the finance and revenue piece from consultants, and then making those decisions at the board level. So this conversation, it felt needed to follow after our enrollment discussion, as we were thinking about, okay, enrollment and who's going to be enrolling and when and what groups. So we want to get this under your all noses for a sniff test.
I would like to compliment the staff, whoever put the slides together. It's a nice job. They're well thought out.
Senior
That would be-
Policy Advisor Hastings is rock star.
Nice job. Yeah.
As is Executive Director McDonald, who's going to take us into Washington's model.
All right. Well, thank you, everyone. Sorry, because I'm simultaneously driving and speaking, which sometimes can get me into a little bit of trouble here, but I'm going to do my best.
You mean driving
so-
the presentation? You're not actually
Yes.
driving. Okay.
No, I'm not actually driving. That's right. I'm driving in my car and talking. And no, even I don't do that. So what I am going to discuss a little bit today has to do with what's happening in Washington State. Now, it's not going to be directly comparable to what the work that we're doing in Oregon, but sort of, again, kind of this is a little bit more, I'm giving a concrete example, but what we're hoping to take away from it is this just sort of larger strategy type discussion. So my plan is I'm going to talk about what's called the Washington Healthcare Management and Coordination System, which is currently in development. I'm going to talk about some key points in development, and then I'm hoping that we can have a discussion about takeaways for Oregon and things that we think are beneficial in the system, and things that are maybe strategies simply even to avoid. So what is this HCMACS? Well, this is essentially an electronic health record that would serve as the electronic health record, not only for the Washington State Medicaid, but also within the Department of Corrections and their Department of Social and Health Services. So just to look at some of those acronyms, the Washington Healthcare Authority is pretty comparable to our Oregon Health Authority. Department of Corrections, you already got that. Department of Social and Health Services is very similar to the Oregon Department of Human Services. And then what they call WATEC is similar to Oregon's EIS, which is Oregon's Enterprise Information System. So what happened was that the legislature had created legislation for a group to mandate and procure and configure an enterprise electronic health record solution. So like I said, it will be this foundational platform for data and workflow management across these large agencies. So it's not all of healthcare in Washington, but it is a significant amount. So this is a huge effort. All right. So the key goals of the Washington HCMACS. So as I mentioned, to implement a unified electronic health record across multiple agencies. Again, just as we are talking about this seamless care coordination and management for the individuals, but the individuals served by those agencies improve care quality and outcomes, enhance the patient experience and accessibility, and then also promotion of population health and cost efficiency. So what I want to be clear about is this Washington system, there's not a billing component to it. So this is different than what we are talking about, but there are, again, a lot of similarities. So different than maybe what a universal health plan information system would be, but there also would no doubt be overlap as well. All right, so how did they get this done, which is pretty impressive? So in 2023, the Department of Corrections, DSHS, HCA, and WATEC, they were charged to develop an enterprise electronic health record plan to establish a program and then procure an enterprise solution. So this plan was approved by the Washington legislature, also their Office of Financial Management and their Technology Services Board. And they were, given a substantial amount of funds through the budget And really what I think was interesting and one of the takeaways is that WATEC was really directed to convene these other groups, HCA, DSHS, and DOC. So they're really, what sort of kicked it off was like bringing together all of these agencies and sort of the mandate, you will create this plan and you're going to create it together. So this enterprise plan was created, sort of like the plan of a plan. We're back into the land of meta plans. And that was approved in November 2023 for the Washington legislature. So then in 2024, the agency, this HCMACS, that's when this program was established. And so that was certainly a very big thing, became up and running. And what next happened, though, also very exciting, was that in 2025, HCMACS had federal funding match approval and resource preparation, which is huge. And we'll talk a little bit more about that federal funding. They also, in 2025, in November of 2025, they contracted with Epic, which is many people are familiar with, is one of the largest electronic health record companies, I would say, in the US. And so that is who this Washington HCMACS contracted with to do a lot of this work. All right. Now I'm showing this not so much that, oh goodness, this is, how we have to follow it, but I think this is a really useful template for large scale information technology change. And so some of the things that stood out to me, you look at 2025, there's a year of foundational pre-implementation readiness and planning. So the pre-planning, I love that. They even put in a little note about when there was a delay. You can see by the red triangles what they call their major milestones when they had CMS approval, and then the Epic contract. So those are two very, very big things as you can manage that. SI stands for system integrator, if people are reading the fine print in here. So that is what they are working on, getting this system integrator contract execution and onboarding. But then next, if you look at it, there's a year of this foundational system configuration that's kind of in this, this phase 1 and phase 2 here. So again, because this is on a quarter, and then if you go into their phase 3, 4, and 5, that's at least 9 something months of training before go live. So again, this is, I think obviously it's very well thought out. Now you will notice that the go live date, it says best case go live now, is later than, so now in 2028, it had been in August of 2027, which is probably not too surprising for anyone who's lived through any kind of large system transformation. That is not an uncommon component of it. But again, I really like this idea of this system configuration that has to happen before anything is ready for work, any of that go live. All right. Sorry. All right. So I said I would talk just a little bit about the budget. Now, again, this is, as mentioned, this is Washington has roughly double the population of Oregon. So this is an incredibly big deal. But the things that I wanted to point out are like, prior to fiscal year 2026, $22.4 million had already been spent on this project, including direct and in-kind agency contributions. Their fiscal years 2025 and 2027 biennium, $240 million are allocated for this. All right, and that's from general fund and Medicaid combined. And we'll talk a little bit about the federal match here. And then in 27 to 29, 200.1 million are budgeted. So as I mentioned, there's a federal match. This federal match, and again, this is for the Medicaid portion, Medicaid population, is actually 68% of the cost are going to be linked to the Medicaid population, and so out of the projected $462.5 million, 314 are coming from the federal government. So I think this is crucial for as the strategy goes forward. Like, how can this happen? This is certainly not a path that will be investigated closely. So, sorry, realize I updated one of my slides. I'm going to actually, oops, apologies. I'm going to go to this one first. So these are just things that came out to me when we're thinking about making a large change for Oregon. And one was that there was this very specific legislative directive for WATEC to convene those agencies. And next, the initial plan was developed and approved, and then this program was created. So that's one thing, that there's significant support through the legislature to make this happen and to have this sort of, I think, the recognition of the importance of this care coordination communication between agencies for people who are served by these agencies is crucial. The level of the funding, I think, is important. Literally millions and millions of dollars were spent even before they put out an RFP, which eventually one of them went to Epic, or the main one went to Epic. So again, all the work that goes into planning for this, and then of course the federal matching funds, very crucial. So that's one part of it. But then the other part I thought was all of the partnerships with these state agencies. And I think this is a really important thing for us to think about here within Oregon, that, within within the state of Oregon itself, there certainly are all of these agencies. Oregon has the EIS, which I said is sort of like their WATEC. The OHA has Office of Information Technology and Analytics Infrastructure. Now, within this whole world, there's something that's called MMIS. Now, that starts sneaking into the billing side, but which is separate, and that's managed by the Oregon Health Authority. And then, of course, in Oregon, the state team is doing a tremendous job. The state-based marketplace team switching the marketplace from a federal marketplace to the state-based marketplace. So again, just considerations that I had about things that are going to be important going forward. And that's really all that I had about this. Again, high level, but I'd certainly love to hear from committee members and our chairs thoughts about this. Yes, Judy.
Thank you. I love this presentation. I was learning something again as you showed it to me when I know that we previewed it. But I think in my mind, thinking about the Washington model, it's important to remember that it's not just in support of a universal health plan, right? It included a lot of other data repositories that we're not looking at, right? Especially like corrections and long-term services and support, like all of the other social services stuff. I mean, it's super ambitious. Good for them, but we're not looking at that big of a pie. But then I also love your slide that shows us like who all the potential collaborators and friends are who are working on similar stuff, because I love nothing more than not reinventing the wheel and just learning from what we've got and trying to use it. So sorry, I guess there's not a question in there. It's just like an observation and a little aha, because the money is a lot.
Yeah, thank you. Thank you, Judy. Lori, yes, please.
So what comes to mind is transparency. I think if you create a system that communicates with each other right from the beginning, I think so much of our problem with costs in healthcare system is because there isn't transparency. It's easy for money to get squandered away and hidden. So I like that.
I think this topic is a great example of where operations committee kind of bumps up right against transition committee and can help like send it off in the right direction, and then the transition committee takes the ball and rolls with it. It's like, what does this really serve, and how big is it, and what does it look like, and how's it built, and what's that cadence and the timeline. And I love also like seeing how long it took them to actually implement or plan it, because they're still in process, and the recognition that there's going to be pauses and there's going to be delays. Yeah, Paula.
Yeah, I like that timeline a lot. And those kinds of clear timelines where it's very simple. And it's also, it's interesting, and I think it's great that they're doing this, because it also shows that these things take a while, right? And so it's interesting as they've been going through, and especially when you're working with a vendor, things never happen when you think they're going to happen. So and also, it's really interesting that they were able to bring all of those departments, I guess you call, together. And I think that's part of what we talked about, of being able to wrap up at a certain time, to have time to get this, to talk to people about it in Oregon, so that everyone knows at the state level, because they don't always talk to each other. They don't know what's going on. And so, that's great that Washington was able to pull that together. So this is really helpful, I think, just to see that it can happen, and how they've done it. So thank you for the presentation on that.
Yeah, Sarah.
Yes, 2 points. The first one is, does Washington seem to be the only state that has something like this, or are there other states that are kind of heading in the same direction or have efforts underway? That's part one. And then part two is that I think from my experience as a nurse that Epic has a kind of a good reputation around Eugene in terms of being able to communicate between our major hospital and other clinicians and so on. And so I took a quick look to see who it's owned by, because it's also very potentially scary to down the road award gigantic statewide contracts to maybe out of state vendors and so forth. And I was very interested to see, where did I have that they've never taken venture capital money, and that their ownership plan is for it to turn into a trust and then even be owned by employees or something along those lines. So that was interesting to me, with some of these fears of how national, what the interests of national vendors and contractors might be, and how they may or may not line up with Oregonian interests.
Mm-hmm. Yeah,
I
thanks
think
for
that is such a great point, Sarah, both about who does own them. And I'll have to say, I will need to do research on what efforts are other states. I just happen to know the Washington team a little bit. So I'm like, I'm going to look into that first. But I think that's a great question. And we can see maybe there's a state that is like already completed. So I definitely will look into that. Thank you so much.
Anna's next, but I just want to comment too. I've looked at Washington systems from a research side too, and it's really powerful to have all of that data together. If you want to ask questions like, if we do X in society, does it make Y kind of benefit in health? Those kinds of questions are really, it's helpful to have that kind of a resource. Anne. Oh, I'm sorry.
We could hear you for a second there, Anne.
Doug, hopefully Anne's giving us a message in the chat, but go ahead if you want to unmute.
Can you hear me?
Mm-hmm.
I'm just curious if California has a system in place. Does anybody know? I realize it's a much bigger state and has a lot more complications, but it'd be interesting. Also, you recall a few years back when OHP, when the CCOs were first getting off the ground and we tried to have a statewide system, Does anybody remember that? Was anybody else here at the time? And there's some tough lessons from it, and Dr. Goldberg could talk about that all day long. But it's, I think it's a great idea. I totally agree with what you've said in terms of it's and one system from a care coordination point of view. It's a wonderful idea. It's very expensive, and that's good homework by Sarah looking that up because we had an experience of taking a company on a few years ago, my former company, taking on a new software. They sold 1 year after we signed the contract. And that was a very difficult situation because the company they sold to did not align with us in many ways. And so that's something else. Just make sure you have somebody who understands contracting with companies like that, A. And B, I agree. If you could look at a couple other states, it might be helpful. Although Washington being next door neighbor, I appreciate that. We already do a lot of things with them now. So but those are my thoughts. I'll stop.
Excellent. Thank you, Doug. Here's a suggestion, and feel free to shoot it down because it's not like a formal recommendation, but I would love for the full board to see this presentation by Dr. McDonald and I think that, our position as operations committee may be the acknowledgement that this exists in Washington. We may be looking at something similar, not to carbon copy, but to, pick and choose the elements of it that work well and learn from their timeline, be informed by the price tag that they're looking at to make it work for Oregon, and then taking the comments from the committee that have been so helpful. Thank you, Sarah and Doug, and how convey to them how important it is to make sure that the first stop is designing the governance for IT and thinking about what does it include and what does it not include. Oh, and Anne, a clarifying question. Can you type it in the chat? Anyway, that's my suggestion. And if anyone feels differently, please bring it up. I'm happy to sit back and not make that, but it may be helpful to the board. Does the transition team create the RFP? I don't think so. I think they create the roadmap. The board would create the RFP, or even the trust itself, the entity, as they're going through that pre-planning process, and then they would be the ones looking at vendors. Is that right, Mimi? Is that what you think? Yeah. Okay. Okay.
Thanks everyone for your great comments as always. And yeah, thanks Chair Richardson. I'm excited to do a little bit more digging into this.
Love it. Love it. Any other committee member reflections? And Mimi, can you let us know about the next steps for this committee?
Yeah, so my heart gets a little bit sad, but the operations committee will have their last operations meeting on the 26th of March. There will certainly kind of have to work a little bit still on the agenda, but this some of it will be possibly bringing back to this committee some of the answers to some of the questions that you posed, for sure. I think there were some incredibly brilliant questions, especially around what Lee Hastings described, and specifically around kind of that question of would there be a consideration of some kind of differentiation when people do have, if they are employed by the federal government, et cetera, et cetera. So I think like the questions that you prompted us will certainly make us work for bringing into that. And then the other thing that I'm proposing to do, like I said, for plan design and expenditure, is to go over the incredible work that you all have done, and it'll just be like a little walk down memory lane, but with the thought that, again, for points that really feel should be clarified, is because sometimes I look back, I'm like, oh, that's what we thought, or that's what they thought. And I think that that will be really beneficial and will be helpful. Like, yes, this is something that we think that absolutely needs to be clarified, and maybe the transition committee can work on this, or this is something that just needs a little bit of subject matter expertise and then could go before the board. So we'll have kind of a wrap up of all the incredible work this group has done.
Excellent, thank you. Any other committee member reflections before you go to comments? Okay. We have a written comment that was provided in the packet. It's on the website materials. It came from Tyson Tucker. Please read that letter. Thank you, Tyson, for writing to us about challenges with having an ERISA plan. And yes, I hope that the Universal Health Plan will be the plan of choice, and at some day you won't have to deal with challenges of having an ERISA plan. We also have a public comment from Lou Sinninger. Is Lou here? He signed up for
Lou, you
oral.
should be able to unmute now.
Thank you.
Hi. Hello.
Hi, Lou.
We can hear you.
Good to see you all again. It's my favorite hobby. So I just wanted to talk to you a little bit about the federal employee. Basically, I used to be a union rep for federal employees, and it might surprise you to know they cannot negotiate benefits or wages for the most part. I don't know of any that do. So basically their benefit plan is approved insurance companies, and you walk around and you see what kind of, insurance company will do you the best once a year. And so needless to say, there's a lot of turnover. But the main point I wanted to get across is that you are not required to take their health benefit plan. So how that impacts, going forward, I don't know. But I thought it might be nice to know that. And as far as our ITech, I think, I mean, it'd be really great if our plan would include a medical card that you took with you to any medical facility that a person wants to go to. They really, as my understanding is, they've really refined that quite a bit in Japan. So it might help out to inquire how they do that. Other than that, I'm sorry that you have to close down on March 26th, but I look forward to talking to you then. Thank you.
Thank you, Lou, for your comment. And thank you to everyone who has provided public comment and written into us. We appreciate your attention and contribution to what sometimes seems like a long and tedious process. Before we adjourn, I want to personally thank each of you on the Operations Committee. I'll probably do this again next meeting, but we've really taken on some of the most complex and rather ambitious parts of this work, and you've done it with thoughtfulness, with discipline, and a real sense of stewardship that is impressive. I'm constantly impressed by your willingness to engage in these hard questions, do your homework, challenge assumptions, and focus on what will actually work in service of a universal health plan. So as we start to conclude our formal work, just remember how much your contributions really mattered and they're carrying forward. And what we've recommended to the board in our work here sets a strong foundation for the next phase of this work, and that's to your credit. So thank you. With that, we'll adjourn.